as I looked at how we were parsing out the information that we were talking about, I thought the most important thing was to try and get the sense of what medical therapy for melanoma is about, and that it's always a difficult challenge because I think for us it's easy after you've done 8 years of education in the area. And it's not so easy for people who have just their life experience to go on and understand our terminology. For those who are looking for specific advice on or information on some of the newer therapies, I'm only going to be touching on things, and perhaps later when we get to the panel discussions, you can ask questions about things you might be specifically interested in. So with that, I'm just going to try and get started, and I'll try not to wander around for you. But I'd like to see the slides. The first thing that I find is important to get across to everyone when we talk about medical therapy, there are really two ways that we think about them, and you should think about them too. There is adjuvant therapy, and there is disease treatment for metastatic melanoma. And adjuvant therapy is technically what is in addition to surgery. And it's the treatment we deliver when we cannot find any disease, but as Dr. Bynes mentioned earlier, it's for people for whom we know they have a high risk of recurrence. And we'd like to deliver some kind of therapy to destroy those remaining few cells that will increase the risk of recurrence later, as opposed to treatment for metastatic disease, where the treatment is delivered and we can see measurable disease or somehow evaluate the presence of disease. We know it's there already. And understanding that concept, I think, helps people because we're in the age of the internet where the sophistication of the people that I work with now is so much greater than it was 15 years ago. And if you understand the terminology and you go out there, you can really make good choices for yourself. Now, adjuvant therapy for melanoma. And this can have a lot of different ways this presents. The most common situation is a patient who has melanoma that has spread to the lymph nodes that Dr. Bynes just described. And these are normally in the lymph nodes that are closest to where the melanoma developed on the skin. And depending on a variety of risk factors, that patient who has melanoma in those lymph nodes has a varying degree of risk that can range from risk of dying of 30 to 80%. And with various risk factors, we can pin that down a little bit. But those are the people that we suspect have microscopic disease that we cannot find. So I'm going to try and give you the short answer and then the long answer for what you do if you know someone who's in that situation. There is one FDA-approved therapy, and that is high-dose interferon. And but we have done over a period of 40 years many clinical trials looking at chemotherapy and other treatments, and they have uniformly been unsuccessful in decreasing the risk for people who have this high risk. So really the currently available cytotoxic drugs, meaning chemotherapy, are really ineffective in preventing the recurrence risk in these patients. What is approved is high-dose interferon. And I'm going to show you that first, and then I'm going to move through some of the other things that one would like to consider in this situation. So the initial national trial for adjuvant high-dose interferon therapy was done 3 decades ago. And the impact of high-dose interferon was looked at after the patients were out well past 5 years, which is our usual endpoint. And we found that the relapse-free survival was significantly improved. Overall survival was significantly improved. And to put that in numbers that make sense to people who think in terms of that, the 5-year improvement in relapse-free survival was improved to 37%, and the overall survival was increased from 37% to 46%. And this was in the days when we did not do sentinel lymph node biopsy that Dr. Bynes just described, and probably changed the whole lay of the land, so to speak, for treating people in this situation. But this was the basis for approving the drug. And usually the FDA doesn't take away approvals once they've given them. So this was the information that we based that on. The interferon is this gold line here compared to what people who didn't get interferon 30 years ago. And if you look at the relapse-free survival over here, and then I want to point out how narrow this is getting here. And finally, when we get over to here, looking at, you can ignore this piece, but this more recent trial, the benefit that's being derived from this is getting less and less. So we're improving relapse-free survival. That's still true. But what we're losing is people aren't really living any longer getting interferon in this adjuvant setting. So it's all about parsing the information. So of course, when people look at the side effects that are associated with this type of therapy and look at the benefit they get, it isn't quite as attractive as it was 30 years ago. And with that as being the only approved therapy in this country, the question is, what do you do in that situation? And that's a dilemma that all of us look at frequently. And there have been a couple other treatments out there that have been looked at in Europe. What's called pegylated interferon has been looked at, and that's a kind of a low-dose version of interferon. The important thing is, you can see there isn't much difference in terms of how patients are surviving when they get or don't get this type of interferon, but it seems to be a very common treatment in Europe because of low toxicity, but certainly doesn't change the outcome for most patients. So what do you do? Well, there are a couple other things to at least look at, and I think Dr. Kaufman will talk about a few of the trials that are available. But in a single trial that was done using a drug called sargramostin or leucine 7 years ago, there was a study looking at this. And this is a low toxicity immunotherapy that's given by the patient at home for 14 days and then 14 days off to complete a year of therapy. And there is now a large national trial which was completed, and we're waiting for those results to then go to the FDA and say, this may be a treatment that could be useful for people. Why would they have done that trial? Well, because Dr. Spittler's work suggested that people who got this sargramostin actually did much better than people from a large university study, that was University of Alabama. They did much better if they got this drug. So it shows some promise, but we don't have the definitive data to say it's useful in this setting, but it has very low toxicity. So sometimes that's something for people to consider when they otherwise have nothing else to work with. There are a number of newer options that have been looked at, and I want to mention these, and Dr. Kaufman may or may not touch on these later. Ipilimumab, and Dr. Gajewski is going to talk, I think, a lot more about this. A trial in this adjuvant setting was completed this last spring, but by virtue of the fact that melanoma can take years to recur, we won't have information from this study for a few more years. And of course, it's not, since it is now closed, it's not an option for people who are looking for adjuvant therapy. There will be a new trial with vemurafenib, and I'll touch on it, and I don't know if anyone else will, but this was newly approved for treating metastatic disease, not available in the adjuvant setting, and a trial will open up at the end of this year to actually ask the question whether this oral drug actually can decrease the risk of recurrence in this setting. So that's the adjuvant situation that we have in the United States today. Then for medical therapy for metastatic disease, and that's a whole different area of treatment. There are a number of different things that I'm going to talk about, and I probably could wander on this talk for the entire day because there's so much information these days to discuss. I'm limiting myself to the things that are on this slide that I'm going to go over. And then later, if you have specific questions about diseases or specific treatments, I think we can go into those at the panel discussion. The standards are, of course, have previously been DTIC. And this is one of my very old slides. DTIC is a palliative therapy in general. It is probably the standard of care at the time that we made this slide. Response rates, probably around 1 in 10 people respond. It doesn't change the survival with metastatic disease with a median survival of 6 months. And typically, survival rates at 5 years were quite poor. And that was the state of the art up until more recently. There's been an oral analog of this drug called temozolomide here, which is also used, and it potentially has the advantage of crossing into the blood-brain barrier and hopefully treating that area. That's theoretical, whether it helps in melanoma in that regard. But these two drugs are essentially the same drug, one given orally, one given IV. Neither improves the overall survival with metastatic disease. This is just a large study that was done looking and comparing these two drugs, and complete responses less than 3%, partial responses about 10%, really not very impressive overall response rates, and again, they lost their effectiveness rather quickly. There are other combination therapies that I should at least touch on because they are still used. A combination chemotherapy regimen we used to refer to as the Dartmouth regimen, and that has actually been compared directly to dacarbazine. The response rates are higher, but their survival isn't any different, and at 1 year, the overall survivorship was no different. Chemotherapy is something that can sometimes give us a decrease in disease, but it is not durable. And one of the key things that I think people have to look at when they're looking at treatment for melanoma and many diseases is, I'm not looking for what I'm going to get in 2 weeks. I want to know where I'm going to be in 5 years. And you have to balance those issues as you're comparing what you're looking at. Interleukin-2 is the first thing that we thought really was going to change the way we treated melanoma in a metastatic setting. And it certainly did result in durable responses, but it was in a small number of patients. The response rates shown here were low. And the duration, however, was much longer than we generally saw with chemotherapy. But patients who got complete responses actually did incredibly well. And these resulted in true durable responses. Now, we don't like to use the word cures, even though I think a lot of my patients would like me to use that word. We think in terms of durable responses. Okay. And in high-dose interleukin-2, we see these durable, complete responders. When we see flat lines on these survival curves, what that means is these are durable responses. We're not seeing people relapse over time after they're done with their therapies. So you may like to go away and call it the C word. We say durable response. And I'll, in the interest of time, because I know we're constantly flipping by, I will skip through this study where we look at interleukin-2 along with a vaccine that was published just a couple years ago that improved response but didn't improve survival. I'm going to touch on biochemotherapy, which is sometimes used when we really need an early response, because interleukin-2 by itself often doesn't give that early response. And so by combining chemotherapy with interleukin-2, we can sometimes achieve about the same long-term durable responses in the 10% range, and still get early response that get the patient out of symptomatic disease. And that's just looking at that flattening on the overall survival curve, suggesting that there are patients who get durable responses with this type of therapy as well, albeit small. But, so we can get responses early on, up to half the time. We can get durable responses about 10% of the time with this kind of biochemotherapy, and there are many versions out there. But it doesn't work well in people with a lot of disease, with many organs that are involved. Those are negative prognostic indicators for how people will do with this. And then I'm going to bring this all home with the new things that have really come up this year, and that's been alluded to in several talks. Ipilimumab and vemurafenib. And everybody will be able to pronounce that when they walk out of this room, I'm sure, perfectly well. And I know that Dr. Gajewski is going to talk a little bit more about ipilimumab, so I won't dwell on any mechanistic slides. That's not why you're here. But basically, this is a drug that works through the immune system. By taking the blunting effect that happens in the immune system and allowing these immune cells that naturally are in the body to now be able to go after melanoma. As Dr. Reddy pointed out, these cells that become melanoma, they came from the pigment cells that were in the skin. And so your body sees those as normal cells. What we want to do is allow them to now go after those cells. And by using this ipilimumab, we allow further enhancement of the immune cells in the body that now can do that. The side effects then can be some cells in the immune system start going after normal parts of the of your body. And that's the toxicity arm of this treatment. But the nice thing about it is we can get long-term and durable responses. And for the non-physicians in the room, here's a patient who started on ipilimumab at the beginning of their therapy for metastatic disease, and this is the liver. And it looked totally normal when they started on this ipilimumab. By the time they finished their 4 doses, which is what the FDA approved, unfortunately, the liver looked like this, and these little dark dots represent new melanomas that have developed in the liver. Well, the treatment got finished, and then from over the next 2 months, the liver started looking much better. And over the next few months, the liver returned to complete normal as the rest of the disease went away. Now, this is a different paradigm shift, not for just you who are looking for a good response. It's different for doctors, too. We're used to giving a drug and seeing a disease immediately get better. That's not what happens typically with this drug. Responses take time to develop because it's waiting for the patient's immune system to start recognizing the melanoma and destroy it. Sometimes seeing a visual appearance of this really brings that message home, and that's why I put a couple of these slides in so you'll remember this. Here's a patient with lots of melanoma that had spread across the skin. By the end of treatment, clearly getting worse. Finished his 4 doses of treatment, and the disease was much worse. So by most of our criteria, we have called that patient a failure on this therapy. And as the next few plates will show you, this patient is far from not being a success. So 2 weeks later, after being clearly defined as a progressor, this is what it looked like. Then another 2 weeks later, and finally, over a year and 2 years later, all disease gone. So again, it's important with this type of therapy to think in terms, have a long-term view toward how these treatments work. Just to reemphasize that this is a type of therapy, somewhat like high-dose interleukin-2, that really does have a unique, what we call kinetics in terms of how it works. And if we try to look too soon, we're going to miss the benefit that this type of therapy has. Some of the patients with ipilimumab have been shown to have these really long, drawn-out responses, looking like they're either progressive or just stable disease, and then followed by regression later on. Some patients really do get an initial response and then go on slowly over months to develop a complete remission. And of course, as the other 2 slides show, some patients really develop new lesions or worsening of lesions and then go on to stability or further response. So again, we have to think differently in this new age of how we're doing therapies. And overall, when we look at ipilimumab, and I'm not going to show you all the trials, just one slide, the flat curve, that this was the very first trial that was published with ipilimumab, these flat lines indicate how patients are really doing. We're really changing the outcome for a significant portion of patients. And this is the difference between having ipilimumab there in the second trial versus not having ipilimumab included. So it's a new class of immune-stimulating agents. It really does prolong overall survival. It's forced us to redefine the guidelines that we recommend to oncologists so that this is a drug that should be used either front or second line in treating melanoma. And there is other development for this type of drug in treating other kinds of cancers and looking at other ways to deliver this treatment, and Dr. Gajewski may touch on that a little more. The last thing I'd like to put in here is the newest drug that was approved by the FDA called vemurafenib. And this is in a class of therapies called targeted therapies. And I think everybody's been used to thinking in terms of drugs being either chemotherapy or immunotherapy. And this is a kind of group of drugs that really isn't either. It really is going into a new age of how we're treating many cancers, which is identifying the defect that is in the cancer and developing a targeted drug that goes after that defect. And I think Dr. Rhodes ran out of time, or he would have gone into this a little bit more, but the defect that we're going after with this drug typically presents itself in what are called the non-chronic sun-damaged skin and represents almost a significant proportion of that type of melanoma on the skin, so the non-chronic sun-damaged skin. And these have this BRAF mutation. When we identify that kind of disease, and it doesn't mean it's any worse, it means we've got a targeted defect, a mutation in that melanoma that is something we can target with this very specific drug. And there are a whole broad range of drugs that are being looked at, and since no one, I think Dr. Gajewski is going to talk about immunotherapies and might not touch on these, I want you to know that there are many drugs that are in development looking at this kind of targeted approach for different types of melanoma. And of course, it's happening in many cancers as well, but it's really changing the way we're treating melanoma as well. The exciting thing about this type of drug, and I mentioned with ipilimumab, you have to have the long view. Well, some patients unfortunately come in and they can't take the long view. They're having trouble breathing or they're having a lot of pain, and waiting 3 or 4 months for a response just isn't a practical approach. And that has always been a difficulty when we look at using ipilimumab. The nice thing about this drug is, and this is a waterfall plot, which is a new way we show how drugs work, looking at the change in how much tumor a patient has. If they didn't have any response at all, they'd sit here at this baseline. If they had progression of disease, it would go up, this one by 100% increase. But look at the number of patients here. They're all dropping off. The response rate is tremendous. About 70% response rate is what we expect with this drug in a patient who has a melanoma with this mutation. And the response rates are often very early. Sometimes we can start seeing them within a week of starting this pill. And the responses can be quite dramatic. Here's a PET CT scan, or PET scan looking at a baseline and then the response 2 weeks after starting on this drug. You can see all these little dark spots, and here, and this is an almost normalized scan 2 weeks after starting this drug. Now, this isn't typical, but it does show you how quickly a treatment like this can in fact work. Another example showing you the multiple dark spots here, and within 2 weeks here, and in another patient, all these areas of melanoma with severe pain, and within 2 weeks, pain resolved and the disease remitting. Now, unfortunately with this drug, although it can work quickly and it works a lot of the time, it does run out of gas after a few months. And so that's the challenge that we have in terms of how to put these therapies together to not only get the effective response early, but then add something in that will give us the durability that I think we all seek. And just to show you a second trial that was done with the same drug, and these are these waterfall plots, which I cannot see from the side well, but I'm sure you can, and it was presented this last year, showing how incredibly good these best responses are with this type of drug. Early response, high response rate, but lack of durability associated with it. And I'm not going to go through the potential toxicities, but they are certainly tolerable. So in conclusion, I'd say the new targeted agents that are focusing on mutations present in melanoma are showing great potential, and we have many new things that we're doing. There are new immunotherapy drugs that are being developed that will enhance the durability of responses. A small number of patients who previously achieved durable responses has really increased dramatically in the past 5 years. And to make that continue, we always encourage participation in clinical research trials. It gives the patient access to the newest agents, and it helps us achieve the goals of making the treatment better for everyone who comes after them. And with that, I'd like to thank you for your attention. I hope I've touched the things you wanted to hear on. Thank you.